with over 2 decades of expertise in nuclear medicine with a clinical focus on oncology and neurology. Dr. Mosci has led the development and implementation of several nuclear medicine departments across Brazil, including the PET-CT facility at the prestigious Armed Forces Hospital in Brasilia. Beyond her clinical leadership, Dr. Mosci is a passionate educator, as she has spearheaded residency programs, has organized international courses with institutions like the Society of Nuclear Medicine and Molecular Imaging, and with the International Atomic Energy Agency, and has served as president of the Brain Imaging Council with the Society of Nuclear Medicine and Molecular Imaging. She has been a reviewer for scientific program and education exhibits committees for the RSNA since 2018 and for the European Journal of Nuclear Medicine since 2020. She is the co-editor and author of the reference textbook Molecular Imaging of Neurodegenerative Disorders, published in 2023. She is currently based in Houston as Director of Academic Alliances at United Imaging. Dr. Mosci remains at the forefront of innovation, education, and clinical excellence. Her work continues to shape the future of molecular imaging worldwide. I leave with you, Dr. Mosci.
Good night, everyone. It's a real pleasure being here with you tonight. I would like to thank Dr. Swawondo and Dr. Jimenez for inviting me to this prestigious location and to this conference. I'll be talking about PET-CT in oncology. There's a question. How does PET-CT enhance clinical diagnostic value in oncology? As you know, nuclear medicine has a functional information. On PET, we are able to see things that happens at molecular level. We can see things that happens before even structural change happens in the body. And we are also very good at quantification. But as you see in the images, molecular image is not very good at spatial resolution. We have limited resolution. And because of that, there was created hybrid equipments where we can merge together molecular imaging, functional images together with anatomic images. And the result of that is that both modalities combined are much better than each modality analyzed separately. How we perform a PET? First, we need a radiopharmaceutical, which is a molecule that will go to a specific target. And in order to be visualized, we labeled it with a radioactive material. So we do inject this substance, what we call radiopharmaceutical, into an individual. And this substance will target specific cells, in case tumors. And after that, we will image where these drugs went through imaging. The most used radiopharmaceutical is FDG, fluorodeoxyglucose. That's very similar to a glucose. What happens is that we change one oxygen into a fluoride, which is radioactive. This change is very minimal, so the glucose can be transported inside the cell exactly the same way as the glucose, and it's phosphorylated. But here comes the difference. Unlike the glucose that follows in the metabolism path, the FDG stays trapped inside the cells, and it accumulates. When you talk about tumors, what happened? Tumors have a very active metabolic activity. They want to grow, they want to go over the whole body. And because of that, we see much more material, much more FDG inside the tumor cells than inside the normal cells, what will be translated as the areas of higher uptake in the body. So how can PET help us? PET can help us detect cancer and stage it, can help on treatment response assessment, on residual mass evaluation, recurrence monitoring, identifying unknown primary tumors, and on radiotherapy planning. FDG is excellent for a large number of tumors. We use it for lung cancer, colorectal cancer, melanoma, lymphoma, head and neck tumors, breast cancer, sarcoma, pancreatic cancer, and others. But FDG is not good for all type of tumors. There are some limitations. There are limitations for renal cell carcinoma, prostate cancer, bladder cancer, hepatocarcinoma, cholangiocarcinoma, neuroendocrine tumors, and some brain tumors. But for these tumors, there are other tracers or other techniques that can be applied to help on this imaging. One example is labeling DOTA-PET. It's a somatostatin receptor a conjugate that link to these receptors that are highly expressed in well-differentiated neuroendocrine tumors. With these tracers, we have sensitivity above 90% for well-differentiated neuroendocrine tumors. And we can detect lesions as small as 2 millimeters with changing in management in up to 30 to 40% of patients. And interesting about this tracer is that we can also do theranostics. What is theranostics? Theranostics is the combination of the two words, therapy and diagnostics. We can use these peptides labeled with a radio tracer that can show where the tumor is located. And after that, we use these conjugates labeled with another radioactive material capable of killing the tumor cells. So we use the same conjugate for doing imaging and then treatment. Later on, Dr. Almaguel will talk about PSMA, which is very specific for prostate cancer. We can detect lesions with levels of PSMA as even below 0.5 on the patients. We do alter patient management, and again, we have theranostic pairing for this PSMA. For breast cancer, specific for those that express estrogen receptor, we have fluoroestradiol PET, which is called FASPET. That's good for therapy selection in identifying patients that are estrogen positive tumors that will show eligibility for endocrine therapy. It's very useful in case of challenging lesions, for example, in place where it's difficult to perform a biopsy, or when the results are indeterminate on conventional imaging. And also, these tumors can be very heterogeneous, and we can, by imaging the whole body, we can have a survey on how is the distribution of this receptor in the body, if there's tumor is heterogeneous or it's more homogeneous. There are other tracers that, and even more being on research pipeline these days. I would like to show some cases on how PET can help us on this diagnosis. So PET can help on lesion characterization. Here we have an example of a 6-year-old male that had a car accident and chest trauma. And during the CT, we found an indeterminate nodule in the left lung. By radiology criteria, this is indeterminate. So are you going to biopsy everyone? And this way, PET can help. We saw uptake. So this was suspicious of malignancy. The patient went to biopsy and was proven non-small cell lung cancer. In another patient, a 62-year-old female with chronic cough, a CT was performed, and we found an 8-millimeter nodule in the upper lobe. And again, we did a PET-CT, and it came negative. And because of that, we are allowed to follow this patient, and she didn't go to biopsy. And the follow-up CT in 6 months and 12 months remain unchanged, proving it was benign. PET has been particularly useful in a non-primary. Here's an example of a 57-year-old man with a metastatic lymph node biopsy on the neck, but all the exams, the laryngoscopy, bronchoscopy, were negative, just showing reactive change. Neither the CT didn't show any alterations that could infer where the primary is besides the neck lymphadenopathy. So this patient had a PET, and we saw a lesion in the base of the tongue. Oops. On the right side, and also showed the metastasis. So PET can indeed improve tumor detection. This is another patient who had a thyroid carcinoma, and on the follow-up, besides having a negative whole body scan with iodine, had increased thyroglobulin, what showed that the patient might be having a recurrency. And we did a PET, and we found a positive lymph node that confirmed to be a relapse. PET can improve tumor detection. This is a case of a male patient, heavy smoker, with a known laryngeal carcinoma that was coming for staging. The PET showed the lesion, the primary lesion, but in addition to that, we saw a pulmonary nodule which showed uptake. And we did the biopsy, and this patient was confirmed with a secondary malignancy. What is interesting is that in patients with head and neck cancer, it's not low the ratio of second malignancy. And the PET has shown to be able to find up to 10% new tumors, secondary tumors, in this type of patients. PET is very good for staging as well. This is a case of a male with progressive dysphagia and an esophageal mass on CT, which show uptake on the PET. But in addition to that, we found an avid FDG, the lymph node, which was confirmed to be a metastasis. So the PET can overstate patients. And this patient wouldn't have been called as metastatic if not based on CT criteria, because this lymph node is small. PET is very well established for staging lymphoma and also for evaluating residual mass. What happens? The patient has a mass and he goes treatment, either chemotherapy or radiotherapy. Sometimes the tumor's dead, it was killed, but the morphological alteration does not go away or just shrink a little bit. And just based on CT criteria, we cannot differentiate if it's a viable tumor, if it's a scar, if it is necrosis. And PET is very good at that. PET is very good to distinguishing viable tumor from necrosis or fibrosis. PET is very well established as a therapy monitoring before chemo and post chemotherapy. And for radiotherapy as well. I want to tell one thing. When we're talking about FDG, we have a very high avidity from the tumors for FDG. But FDG is not specific to tumors. We can see FDG uptake in certain situations, such as inflammation and infection. So we need to be careful when dealing with radiotherapy treatment. After the radiotherapy treatment, we have some inflammation in response to that. So we need to wait around 3 months to have a better evaluation of these patients. Otherwise, we cannot distinguish if what we are seeing as uptake is a real inflammatory change or still tumor that was viable behind. So this is a case on a patient who had a radiofrequency ablation that we see the uptake before the treatment and absence of uptake after the treatment. And for radiofrequency ablation, we should wait around 2 months to avoid these inflammatory changes related to the procedure. PET is very good in evaluating recurrency, especially in situations where the treatment led to alterations in morphology. So this is a 60-year-old male patient who had laryngectomy and now was presenting with progressive dysphagia. The question is, what I'm seeing is just post-surgical change? Is it tumor recurrency? And guess what? PET can clearly delineate that. PET is being very useful for radiotherapy planning as well. When we plan the radiotherapy based on CT volume, CT tumor gross volume, usually we can include areas of atelectasis, areas that are not real tumor. So the area of irradiation is usually larger than what we see with the PET. So whenever we apply PET for this planning, we can spare tissue of being damaged by radiation that wouldn't have any benefit of it. But all methods have limitations. When we talk about FDG, we have to be careful if we're asking for the right radiopharmaceutical. We have to ask for a FDG PET for the tumors that are avid. And we need to take care about the preparation because we need fasting for FDG. And be aware of situations that where we could observe false positives, such as inflammation and infection. I'll be talking a little bit later, but we can have false negatives due to very small lesions. And this is related to the method itself, but different equipments have different power of identifying small lesions. PET is not indicated for screening. There are false positives, as I mentioned before, so we don't use imaging method that has radiation with a patient that likely will not benefit of it. And PET will not see microscopic lesion. As an example, we cannot substitute a sentinel lymph node in breast cancer because we won't have resolution to see microscopic lesions. And even very early tumors on head and neck, for example, T1 tumors, can be very small or very shallow, that the best way to access it is through video. Not fasting. Not fasting for FDG. Okay? Because when patient is not fasting, there's a lot of glucose circulating in the blood. And glucose that's not labeling. So the glucose not labeled can go inside the cell and compete for the one that's going to track the tumor, the FDG. But one important thing is that we are in the era of precision imaging on empowered decision. And not all PET-CT are the same. you might have heard about, is this an analog PET? Is this a digital PET? But technology goes much beyond there. We started with crystal on the technology, but the technology evolved so much. So nowadays, the capability of seeing lesions and how we see it is much beyond the crystal or being digital or detection. We talk about getting better spatial resolution, time of flight, sensitivity, axial field of view, types of reconstruction, and motion correction. But at the end, what do you want? We want lower radiation exposure to our patients, shorter scan time. These are cancer patients. Sometimes they're in pain. We want to see more detailed imaging. And at the end, better disease diagnosis and progression analysis. I just want to show you how the technology evolved over the time. So we are now on the 3rd generation of PET. If you look from the left, to the right, all are PET-CT. But look the difference on what type of imaging, how you can delineate the structures and see details. Do you think this PET will have the same result as this one? And they all will be called PET-CT. So we have to be aware of that. And I'm glad to tell that Dr. Zawondo is here on the 3rd generation. And it does make a difference. It does make a difference when we see small lesions such as this small lung nodule that can be seen with a new generation PET and cannot be seen on another one. We see these differences in lymph nodes, we see in peritoneal metastasis, and imagine this change patient management. We can avoid a patient of having unnecessary surgery, unnecessary morbidity that he won't benefit from. We're gonna save money from the reimbursement from the health plan that will be investing money in a treatment that won't serve any better to the patient. So having the right diagnosis is extremely important. Good question. Usually, we don't get very attached to numbers. The very experienced physicians can identify by eyes, but in experience, there's a learning curve. So sometimes I can call a positive a node because it's very tiny, and I can call it positive with 1.5. But with the technology, like the higher technology equipments, we have much less effect on the size, what we call partial volume effect, and we have more real values on SUV. Like here, we could see a little bit of this node here, SUV 1.5. But when we use a new technology equipment, we see that this value, that if you're very experienced, you could read this as positive. It's hard. It's gonna depend on a lot of factors. But when we see it bright as it is, with a higher uptake, you have much more confidence in calling it positive. And this is exactly what Dr. Zawondo is showing here. So I thank him for let me present some of his cases, because I think it's very important. It's very important to tell that you're getting the best exam here. Dr. Z is being able to see very tiny lesions here, like this one here on the spinal cord. These are kind of 3 millimeters lesion that are not easy to see in older technologies. And these metastases, they could be confirmed later on with the MRI. And talking about a good equipment, we are not talking just about FDG. We are talking about all type of tracers. We are talking about gallium tracers. We are talking about seeing small lesions as small as 3 millimeters in the spine, not visible on CT because the metabolic findings, the functional findings, we are able to see before the anatomic changes. And very small ones, even with traces that not as good as fluorine as gallium. We are talking about excellence in all type of tracers. We are talking about seeing very tiny lymph nodes in patients with prostate cancer, image with PSMA, that we can see 3 millimeters lymph nodes. And we can see not just 0.44 milligrams of PSMA. We can see 0.2. And we see lesions that are very close to the bladder. And we still can see, because usually when we have a very high uptake area near tumor, it's harder to find. So with good technology, we can see better. We can manage patient better. And with that, I want to thank you all. And I would like to finish with a quotation from Dr. Wendy Wagner, that's considered the father of nuclear medicine. He used to say that PET-CT is the stethoscope of a modern oncology that reveals what the eyes cannot see and the fingers cannot feel. And on my side, I say if you want to really give our best to our patients, we need to use the best machines, the best stethoscope, the best PET-CT. Thank you very much.
Initializing scan.